Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training.
All right, guys, so today we're going to talk about a basic approach to looking at gallbladder ejection fraction. This is a very straightforward exam. The basic structure is to understand what's going on with the patient, and probably the most important thing is to assess the technical quality of the study, particularly that the region of interest is positioned appropriately, and then we'll go through and take a look at how you actually figure out that ejection fraction. Frequently this is going to be automatically calculated for you, but we'll just kind of go through some of what the study actually looks like. Okay, so this is what such a study might look like. The kind of major considerations when you're doing your homework of basically understanding, the various components of the clinical picture is you want to take a look as to whether the patient had a prior HIDA scan, ultrasound study. What is the actual concern? Is there, what is the clinical suspicion for, biliary dysfunction, chronic cholecystitis, or any other sort of alternative explanation for the patient's symptoms. Here we have on these images, once you understand what's going on, you can start taking a look at the actual study, and here you have kind of the scintigraphic appearance over time from frame 1 to frame 60. And as we go down and we kind of go and this kind of summative image here, the most important thing is going to be to look and see that the region of interest was placed on an area where we actually expect the gallbladder to be. And you can correlate this with any sort of prior HIDA scan or anatomic imaging, CT, MRI, to make sure that that anatomy is actually where the gallbladder is and not some sort of thing that's going to be like a fake out. And once you have that sense, you see if the patient's moved and if that's tracting appropriately and actually on the expected area. The next thing is just to take a look at how the scintigraphic activity has gone down over time, and over the course of this the study duration, the threshold for calling normal is going to be different depending on the institutional protocol. At our institution, it's 35 ejection fraction. After CCK is administered during the study. So here we have 40%. So you can kind of see this activity diminishing over time, and that's indicative of a normal exam. We have some specifics here of when the activity was measured. But basically, if you do see abnormality, you're primarily thinking about chronic cholecystitis, biliary dyskinesia. There's some uncommon differential considerations, including sphincter of Oddi spasm, cystic duct syndrome, chronic acalculous cholecystitis, and as a result of medication or medication side effects. So that's going to be something that you want to have a sense of when you're looking at the patient as well. And then, on these images, just kind of as for due diligence, just looking outside of the biliary tree and GI system to make sure that there's no abnormal tracer in the same way that you might do kind of as one of the checks during when you look for on a HIDA scan. That's basically it. So just to summarize, the major points are to get a sense as to what's going on with the patient, the suspicion for potential chronic chole or biliary dyskinesia, and then really making sure that ROI is in the right place, and that familiarity with your institutional protocol and the thresholds on where to look, or when the ejection fraction crosses that threshold to be a normal abnormal study.